And Doc, when we're considering, I guess, follow-up or building on this, again, you said very limited, unfortunately, by available state data, very understandable circumstance. But is there anything that you guys look at in terms of this data set and say, okay, this is where we go next. This is how we can compound it. This is how we can expand at this point?
Yes, so as I mentioned, when we first started this project mid-March, only 23 states were reporting some sort of data on hospitalizations and very sort of in a very sparse way. And we were calling for an action that, we need to know hospitalizations current hospitalizations, so the census, and we also want to know hospitalizations to date, sort of a cumulative measure. And we want to know the same for ICU, because we really want to understand transitions from some more mild, perhaps, hospitalizations to the cases that become more severe. And I'm really happy to report that, it's still not perfect, but all the states currently report some measure of hospitalization. So we have this really ongoing effort every single day, very methodologically. We keep collecting this information, and we make it available publicly through our website, University of Minnesota COVID-19 Hospitalization Tracking Project. A lot of the things that we're looking at now is the reopening question. So we're looking at basically still collecting data, because we want to, reopening started about a couple of weeks ago, but we want to give it a little bit more time as to really being able to see changes in hospitalizations and variations across states. So our ongoing analyses are looking at the impact of reopenings and how the different states reopen at different times on their hospitalizations. In another set of studies, we're building the link between hospitalizations to COVID-19 related deaths, because that's another metric we want to understand as to what % of these severe cases then lead to mortality. Some of these states are making available data in a sub-state level, like at the county level, for example, which is really important too. And to be able to understand within a state the variations in hospitalizations. Are rural areas experiencing this very differently than urban areas, for example? And then, of course, race and ethnicity and age demographics in hospitalizations is another project that we're working on.
That's excellent. That's great. And another point that I think that could really benefit from understanding all those subsets a little bit better, because, as you're saying this, it's very clear that the dimensions of COVID-19 are very particular, but also greatly encompassing. It has like patient subpopulations that are more greatly affected by age, stratified by race, stratified by gender, stratified by comorbidities. It's rural and city differences. Very obviously, New York City has been greatly affected. It has become the epicenter of infection rates. And I am interested to learn and see if we can learn, I guess, the inverse of these findings, really, that if there is an association between not following social distancing protocol and an increased risk, because obviously we can't just say because we know staying home has reduced, we can't say that also going outside is just putting you at risk. So I think that especially is going to really benefit from learning more about that. So that's excellent.
Yeah, absolutely. I'm very curious about those findings we're going to get, because it's, as you said, it's not necessarily the reverse image either.
Yeah.
So, and I think another hard fact here is, until we have a vaccine or a very clear, medical treatment for this disease, states and other local decision making will have to be around strengthening social distancing, relaxing it, giving some fresh air to the businesses, but then maybe if needed, pulling it back again. I think we're going to have to go between this, I want to call it sort of tightening and letting go kind of policies. And so really understanding how each dimension tightening does too. This very important health outcome as measured as hospitalizations versus how letting go does it to the same is going to be really important for a more complete policy decision-making process.
Yeah, it's interesting to see how these sort of findings are going to exactly inform the initial phase of reintroducing normalize society again, understanding that there is value in doing this, and okay, how exactly do we go about proceeding that? So I mean, it's interesting too, because generally what we cover on our publication is news that's impactful for the clinician speaking to the patient. This seems to be news that's impactful for the clinician speaking to his legislator, for his, you know, the decision maker, his bill passer, to emphasize to them that we have the data showing there is a procedure and a value to what we've been doing. So we need to.
Absolutely. But also, you know, from a clinician point of view, that, you know, hospitalizations, of course, is, and the impact on hospitalizations has really exposed our healthcare system as to how reliant we are on the hospital system. And at the same time, I think this kind of a study has implications for creating clinical opportunities to see patients outside of the hospital system, outside of the clinic system, and being able to somehow help with the social distancing. And, you know, even if there is not a stay-at-home order, being able to manage the clinic visits in a way that does not require people to be out if they don't have to be, like the impact that we've seen on telehealth, for example. It's amazing. And I think offline, you and I were talking about contact tracing. I mean, and I think another big role that falls into the healthcare professionals is this idea of contact tracing, and being able to really find out who can be outside in the streets and who really need to stay home and who really needs to be managed in a different way. Just a little side note, I'm originally from Turkey, and actually my parents happened to be stuck in Turkey because they visited there in late December and they could never come back. But and they're 65 and older, so they are under strict curfew to stay home. But they're telling me the way it's managed over there, there's what they call is like a general practitioner, like a family medicine physician assigned to a single family. And if there is any question about COVID-19 testing, even if the test comes negative, these families are under contact tracing managed by their family medicine physician, which was really interesting to me, that the contact tracing is managed by the healthcare system more directly. Over here, it's you hear more of the public health departments taking in charge. But it does make sense in some sense that the family medicine physician knows the most about you, and it creates a contact opportunity. They call every day to figure out if you're doing okay and check your symptoms, and just kind of encourage you, gotta stay home.